Well, the premise of precision medicine, first and foremost, is to match the right patient with the right treatment at the right time. Immune therapies or checkpoint inhibitors have been very successful in a subset of patients with multiple different types of malignancies and has changed their trajectory tremendously. For example, melanoma has had a very high success rate with the immunologic therapies. As we all know, it's where we started out, and President Jimmy Carter had actually gotten an experimental checkpoint inhibitor for his melanoma, which had traveled to his brain and has been disease-free for a number of years, potentially even cured, which doesn't happen often, but it can happen with these therapies. Additionally, there are lung cancer patients who have also benefited tremendously from these therapies. Case in point are patients who have had greater than 50% tumor proportion score of PD-L1. These particular patients tend to have a very strong and lasting response to these drugs. However, it's only about half of the patients who have these parameters. I think there's a lot of questions that still remain unanswered with them. I think they're great therapies. They're here to stay and do benefit some of our patients. But my questions still remain: what is the proper sequencing of many of these agents? You know, what should we be doubling them up with? Should we be doubling them up with anything? And why are there patients who, in all rightfulness, should be responding to them are not? Is it because of their innate immune systems? Is it because of other underlying comorbidities? Is it due to other problems within the microenvironment of these tumors, or just even their microbiome? That remains pretty unclear at this time, and I think there's a lot of work to be done.